Welcome to the Reapparition Journal podcast, where we explore the intersections of storytelling, humanity, and health. I'm your host, Taruni, and I'm the founder and editor-in-chief of Reapparition Journal. Each episode invites conversations with clinicians, writers, ethicists, and scholars whose work expands on how we understand suffering and resilience. I'm thrilled to have you join us for this very special conversation. Today, I have the enormous honor of speaking with Dr. Tony Weiss, psychiatrist, senior clinician, and chief medical officer at the Beth Israel Medical Center, and associate professor of psychiatry at Harvard Medical School. His work spans clinical care, leadership, education, and systems innovation. And across all of these domains, he thinks deeply about the interplay between identity, memory, narrative, and human behavior. Our conversation today will explore questions at the heart of psychiatry and the humanities. How do stories shape the self? How do clinicians witness, hold, and respond to patients' evolving narratives? How do leaders in medicine navigate moral complexity? And what will the future of psychiatry look like in an age of AI, digital phenotyping, and algorithmic decision making? We'll also use a story many listeners may know, Flowers for Algernon, as an entry point into discussing cognitive change, identity continuity, and hope. Dr. Weiss, thank you so much for being here. It's truly a privilege.
Yeah, thanks for having me. Pleased to be here.
So I'd love to begin by looking at psychiatry through the lens of narrative. Something I've always been struck by is how psychiatry uniquely incorporates the story. Unlike in other specialties, the data of psychiatry, so to speak, is often the patient's lived experience, like their history and their internal logic and so forth. And this reminds me of how Carl Jung once suggested that people are always telling a deeper story than the one that they may say explicitly aloud. And in my understanding, you're constantly having to navigate those layers in psychiatry. The explicit story a patient presents, the implicit emotional story underneath that, and then there might be also this deeper story shaped by memory, identity, and history. And so my question to you is in clinical practice, do you find that to be true? And when you're working with patients, how do you listen for that story beneath the story, so to speak? Maybe the part that's not immediately articulated.
Yeah, well, that's an amazing question. So, I I think that psychiatry is not too different from other medical specialties, and I think as we look at what does it mean to be a physician, or what does it mean to be engaged in helping other people, for me, it goes back to what is our role as humans helping other people? How do we think about what our brains actually do? So for me, I always bring it back to first principles, and I bring it back to my first love, which is thinking about the brain. And when we think about what the brain is meant to do, the brain is meant to have a role in integrating the person. It actually serves a pretty important regulatory and oversight role for internal functioning, um, navigating what's all happening inside the person in their embodied self. And then it also helps them navigate in the world with others and in the environment. And in both cases, what it's doing is trying to make sense, meaning making, if you will, about what's happening. So let's, for example, start with the inside. So you're having pain in your right upper quadrant, and you're having weird colored stool or something like that, right? Like, what does that mean? Like, how do you make sense of that as a human? Your brain is going to try to make sense of that. And the role of the physician in that particular case, again, probably an internist, would be to say, okay, I'm seeing these symptoms, these data points, this information. I'm going to make a story out of that. And that story is typically going to be a diagnosis. Based on these information points that you're telling me, I think what's happening is you've got some issue with your gallbladder, or some issue with your liver, or and let's find out what that is, and we'll go on that journey together, and we'll understand that together. And in doing that, what the physician is doing is supplementing your brain's ability to manage and understand what's happening internally and make sense of that, right? And creating a narrative through diagnosis, creating a narrative that helps take the complexity, scariness, chaos that is the internal environment of your body and to make sense of that for you, right? To add that layer of explanation. Um, that's really the role of all physicians. Now, some physicians obviously then have to help the person to actually take out the gallbladder, right? So there's proceduralists, but as we think about the role, especially of cognitive physicians, in more general terms, physicians overall, it's really to help make sense out of what's happening inside the body, creating a narrative, typically through diagnosis. And that's the way we speak to each other as physicians as well, is we'll tell each other narratives. This is a 28-year-old woman with X, Y, and Z and came with this problem, and here's what I think is going on, and so forth. Now, in psychiatry, there are some of those same issues. So someone who is experiencing a lot of fluttering of their heart, or is sweating whenever they go out and do public speaking, or is not sleeping well. So the internal regulation of sleep, of appetite, they're reaching for crappy carbs all the time, when they're feeling emotionally upset. Those types of internal regulatory functions also need to be kind of understood and explained and brought under the umbrella of some type of narrative. And I think that is an important role for psychiatrists. But in addition to that internal function, the brain also serves a very important function in making sense of the chaos of the external environment as well. And that's more often where psychiatry gets involved, is how do we help people who are having trouble in making sense of that world and their place in it, their identity, or the role that they play, or why they're having trouble in navigating that world. How do we as psychiatrists help them to understand that? And once again, it's typically done through understanding, hearing their story, and then bringing that in line with some sort of diagnosis. Now, I have to say that psychiatry has not done a very good job of that, especially I'd say in the last, I don't know, 20 years or so. I think what's happened is that the type of story that we're using now, the type of narrative that we're using to help people to navigate the chaos and complexity in their world has been flattened. And it's shifted. It's really changed, right? So when you think about the type of stories that society would tell each other about these kind of experiences, that's completely changed from, you mentioned Jung, from myth, kind of religious overviews of what might be happening, metaphysical, and there's a hunger for those kind of explanations, right? And there's a reason why we keep coming back to those explanations. Those have been stripped out of most of psychiatry, almost completely removed, and that explanatory frame has been reduced to, well, you've got bipolar disorder, or you have panic disorder, and while there's value in the diagnosis, there's value in letting someone know that I've seen other people with this situation, and all the chaos you've experienced with the fluctuations in your mood and with the problem sleeping and the issues with your weight and all of that, I've seen that before, and it's called X, right? There's value in that, but it doesn't really help ultimately in sense making, and I think it falls very short. And I think the other place where we've really kind of missed the mark is then that next level of explanation, which is, and it's probably because of some serotonin changes in your body, right? A, that's probably not 100% accurate, and B, that doesn't really help someone to really make sense out of the chaos, right? Because it's very hard to draw that link between serotonin and this, right? So I don't know where I'm going with this, Taruni, but I do think that is the role of psychiatry. I don't think we've done a great job of it, and I do worry that as diagnosis gets flattened even further to not just say you have bipolar disorder, but you have, for example, as we move more to physiologic measurement, a lot of people are wearing these rings now or Apple Watches or what have you, and of course that's digital psychiatry is on the horizon and can have a very important role to play. But if we reduce everyone's experience in the world, their experience of their own body and their experience of what's happening around them to a number, I don't think that that's going to have the value that people are going to be looking for in navigating that world.
Yeah, I mean, and thank you for that. That was really insightful, and it really touched upon this like importance of meaning making, I guess, from the patient's perspective. And I think that segues beautifully into another aspect that I wanted to ask you about, which is how narrative and memory interact. Where memory isn't like a perfect recording; it's selective, reconstructive, and reconstructed constantly, and probably also sometimes a protective mechanism for patients. And so I'm curious how you see memory shaping or reshaping a person's sense of self, their sense of identity, and their sense of meaning making in your clinical work.
Yeah, excellent question. I think let me broaden it a bit because it's beyond memory. It's about the filter that is the human and how they select aspects of their story to share, right? And every time we tell a story about ourselves, um, we are selecting information to share or not share, right? And that may be because of the insight we have into our own situation, limited or expanded. It may be because of actual cognitive impairment, that we don't have the capacity to connect to, let's say, the memory of something. And so it gets retold in a fragmented sort of way. It may be because we don't have access to the affects associated with some of those experiences. And so the way that I share that narrative may come across as affectless, right? All of that is really, really important because it helps certainly the psychiatrist or the physician to understand, um, you know, what filters are being applied to the information. For some people, I teach a lot of the Harvard medical students, and psychiatry and to some degree neurology are really tricky areas for the students to, they can be very frustrating because physicians rely on that initial narrative, and although in a lot of areas of medicine now there's other ways to probe the body, so to speak, or probe the physiology, psychiatry and neurology, especially psychiatry, are pretty much reliant on the narrative, and yet almost by definition, that narrative will come across in a fragmented, affectless, or different format, right? And that can be very frustrating if you just want to hear, okay, well, like, what happened next? Like, okay, tell me what happened next, right? But what's really valuable is that it is in the fragmentation of the narrative that you can see where the challenges are. So if someone has, let's say, frontal lobe impairment of some sort, and they're not able to cohesively provide a linear narrative from start to end, right? And they're all over the place. That in and of itself is the problem they're having. That in and of itself is the issue, right? They're showing you what that issue is through the way in which they're telling it. The same would be true about memory. So if they can't recall major pieces of their historical situation, that's critically important, right? So rather than getting frustrated, I try to help the students see that that's really valuable because then you know what role you can play as another human, as a physician, as a psychiatrist. It could be to help them to organize their thinking, to help them to organize their life. Because as you're seeing this fragmentation, or as you're seeing gaps and holes, that must be incredibly scary, because the world is chaotic enough. The world is challenging enough, right? The environment that we're living in now is fast changing enough. But now imagine strobe lighting that, and you're only seeing fragments of that, or you're trying to make sense of the world and it's coming at you in different angles and you're having a hard time following along any of it, right? That's really difficult. And that's why this person that's coming to me is having difficulty navigating life, right? And so it's in that narrative and in hearing that narrative and in seeing the way in which the narrative is constructed that I can help understand what sort of problems they might be having. And then more importantly, I guess, what sort of role I could play in helping them. Um, and that's why I think there's some really good, literature can be very, very helpful in that regard because there are some narrative structures in good literature that are not, first this happened, and then this happened, and then this happened, right? And so seeing and reading and getting used to challenging pieces of literature that are, either, like William Burroughs or someone who's kind of thrown everything together and you're trying or J.G. Ballard, another really good author, is very helpful. It's good training for my mind as a psychiatrist and as a physician to help understand how I might be able to interact with people who aren't able to provide that kind of cohesion in what they're saying.
Yeah, that's fascinating, and I think something that you alluded to there is this very powerful, like almost joint curatorial power that the physician has along with the patient. And so one thing I was wondering is when you sense that a patient is holding on to a narrative that's protective maybe to them, but also limiting, how do you know when it's clinically appropriate to challenge it versus leave it intact?
Yeah, that's a really good question. That's a very subtle matter, right? Because you want to co-create that narrative. You don't want to impose the narrative, and that's why I think blunt diagnoses are sometimes, I mean, they're sometimes very valuable. But in essence, what you're doing is flattening their entire worldview and perspective of themselves into a label, right? You're saying you're you're a bipolar, right? And so even in presenting that diagnosis, you have to be very careful to make it clear that this is not the sum total of how I see you. This is something that could help us to navigate the chaos that is what it's like to be someone who is living with bipolar disorder, as an example. But yeah, this balance between how much of someone's identity, the narrative they're telling themselves, the way in which they see themselves in the world, how much of that comes from inside, um, and how much of that can come from the outside. And there are some people who, because they're so um, challenged, I guess, in coming up with a cohesive understanding of themselves, that they'll lean more heavily on someone else to help patch that together. That can easily lend itself to dependence, right? And so you've got to be careful about that. Um, but you also need to help them because having a fragmented and patchwork kind of understanding of your own self is not a good way of going out into the chaos, right? And so kind of helping them to kind of fill in those gaps or helping them to create something a bit more cohesive or making sense of why this happened and then that happened um, can be very, very valuable. It's also interesting because again, almost by definition. So when you work with people, let's say who have schizophrenia, and they've gone through a pretty severe psychotic episode where they have profound delusions, maybe they have hallucinations. Um, for the most part, people with schizophrenia don't live 24/7, 365 with those symptoms. Those are in pieces of their history. Those are pieces of time when stress overwhelmed their nervous system. That's the way how I think of it. And they had an emergence of these symptoms. But by definition, almost by definition, those periods of time are blurry. People are not laying down crisp memories of their experiences often when they're going through severe psychosis or when someone's manic. When someone's manic, things are happening so fast in their head and the world is happening at such a speed that they're not laying down crisp memories of that. And so the person who comes to you then, having had these experiences, may not remember any of it or may remember it only as kind of a shadow of what happened. And so it can be useful to help fill in those gaps with some factual information, because if they don't remember much of that, then it doesn't serve as kind of a warning or a rationale to do anything differently moving forward, right? And so there is some value in filling in some of those pieces, but not doing that in a way that's too heavy-handed or that overrides their own understanding of themselves.
Yeah. And I think you touched upon this a little bit in both this response and an earlier response, but like, how do you think physician training or like medical education more broadly can better teach narrative competency? Do you have any like advice or thoughts on that?
Yeah, I think it is through, well, I mean, I personally think seeing and interacting with as many people as you can is really important. And just feeling comfortable hearing the story, listening to the entire story, and then trying to kind of understand where that person is coming from. Um, Time pressures, training pressures, limits on the amount of time one can spend, um, I think are factors that are challenging that, as well as this idea of the kind of the brass ring of technology, right? And so, wouldn't it just be easier if I had a little wand, to like do this and that I get all the information I need to know, right? And yes, I mean, at some level, there's value in that little wand, right? Whatever shape that takes. Um, but that can also pull people, young physicians, away from hearing more about those stories. And I think that's to our detriment as a field. Um, because as I think about it, and I think about what lies next for medicine, for to some degree for psychiatry, um, we will have more of those little wands. We will have the ability, whether it's through these rings or watches or wands or what have you, to understand the physiology in a way that we've never before had the capacity to understand. We may actually be able to, this is science fiction, to measure serotonin levels or dopamine levels, in real time in the brain, or see neuronal firing in real time, or whatever. But that I don't think is going to help this person kind of make sense of like, why is all this happening?
Yeah.
um, and what can they do about it, and who's going to accompany them into the chaos of what lies next for them. And unless physicians, and especially psychiatrists, stay attuned to those aspects of the story, I don't know that there's going to be anyone. It's not going to be a chatbot. I really don't think that, at least not at present, the chatbot's going to be able to incorporate all of this and have the trust of the patient to help them to navigate these worlds, this world, these worlds, I guess, even as we think about virtual worlds that people are trying to navigate as well.
Yeah.
But I don't know. I mean, the other thing, obviously, you're aware that we've started a class at Harvard Medical School in the master's program for bioethics on narrative medicine. And this is not new. There are other professors and teachers of narrative medicine, but John Rhee and I are leading a class trying to focus it on virtue ethics and also thinking about the interaction of identity and technology in particular, using science fiction, using other stories to try to help bolster those kind of skills. And I think I think physicians, ethicists, um, anyone who cares about the human endeavor could benefit from more literature reading.
Yeah, definitely. It's a wonderful class. But this conversation about memory, identity, and the way people construct their inner narratives is, I think, ties in wonderfully with a story that is actually discussed in this very class, Flowers for Algernon by Daniel Kays. Um, and for listeners who may not have read it, we'll link the story in the description. But Flowers for Algernon follows Charlie Gordon, a man with an intellectual disability who undergoes an experimental surgery designed to dramatically increase his intelligence. At first, the procedure seems miraculous and successful. Charlie's cognitive abilities rise rapidly, and he gains access to intellectual, emotional, and relational experiences that he's never had before. But then, as the story progresses, we see that this ascent comes with a very painful self awareness. He begins to perceive the ways in which he was previously mocked, misunderstood, even infantilized. His emotional world becomes a lot more complicated. His relationships change, and the cost of knowledge becomes increasingly clear to him. And eventually, later on in the story, the effects of the surgery reverse, and Charlie reverts back to his original self. His cognitive abilities decline, and he becomes almost heartbreakingly aware of what he's losing. And so this story more broadly forces us into questions about identity, autonomy, and what it really means to improve a person. And so with that framing, I'd love to hear your perspective. To start, what do you feel resonates with you in the way that Flowers for Algernon depicts cognitive change and emotional vulnerability? And are there elements that feel familiar in your clinical work?
It's an extraordinary story, and it endures. I think it's over 60 years old now, but I think there are three pieces to it that um, directly follow from the conversation we've had so far. One is that the way in which the narrative is told is through um, the it's first person narrative, and it's told in a way that it starts out very broken, right? And you see that in the phrasing and the wording, and it gives you a lens as to what it might be like to try to meet this person where they are and to understand where their mental life is, even if it's not as coherent and linear as you might want it to be. And so I think it's one of those stories that uses the language and the narrative structure to help in conveying what the inner world of this person might be like, which is amazing. Second, it talks about that kind of forced realization of one's self-identity, right? And so just as we were talking about how that needs to be done carefully and subtly, providing a diagnosis or providing a, a narrative or an identity, that's what happens in this story. Now, it doesn't happen from a psychiatrist doing this and holding up a mirror to Charlie, but it happens through the intervention of medicine or healthcare or technology, right? And while there are positive aspects to that forced kind of re-examination of his life, right, as you say, it also comes at the cost of a lot of pain and challenge, right? And then finally, I think this story does a really nice job of not just flattening his world into an IQ number. And the whole story, the whole book could be told with just three IQ numbers, and you could chart that out. And I'm not going to give away any spoilers, but it starts out low and it goes up, and then um, but that wouldn't be hardly any interest to anyone really, and not of any help in terms of understanding other people or understanding the world. And I think that's what's so brilliant about Flowers for Algernon.
Yeah, and one of the other deep tensions in the story that I wanted to touch upon is between hope and honesty, particularly in the context of the clinicians and the researchers in the story. And clinically, how do psychiatrists navigate, or physicians more broadly navigate that tension with patients whose cognitive capacity is changing, whether it may be because of dementia or traumatic injury and so forth?
Yeah, again, that's that's really challenging, because for many people, especially people who have given up hope on their life, or are thinking about ending their life, or for those where there's some genuine changes to their cognitive ability, and their lives are maybe actually nearing their end. Um, Maintenance of some sort of hope is sometimes the best thing that a fellow human, or in this case, the psychiatrist or physician, can provide. But you also want to be careful that you're not providing false hope, um, or providing hope just to like who's benefiting from this? Is it just to make me feel good, that I'm doing something, or is it that this is actually benefiting the person? Um, but that's where I think having a sense of trust, and building up that relationship in advance, hopefully, is so critically important, because then you can navigate that together, and kind of right size that conversation in a way that makes sense for the person who's seeking the help in the first place.
Yeah, and you brought forth some of like the ethical considerations there as well a little bit, where the story puts pressure on ideas such as autonomy and consent and paternalism, um, like even the desire to restore someone to a previous version of themselves. And so, what ethical insights, or more broadly, do you think the story offers clinicians? And what kind of more salient learnings do you think are there?
You're talking about flowers for Algernon in particular, or just in general?
Yeah, I mean, maybe in general as well. Yeah.
Yeah, I think what I've learned from narrative, and I go back to, I mean, I got into ethics. I got into ethics early on in my career, but I was reintroduced to it through a series of books by Ramiz Nam that were published in the mid-teens, 20 teens, related to neuroethics. And these were these were eye-opening for me, because then I saw that these complex issues that are at play in society, um, issues that are way too complex to summarize in kind of a this is right, this is wrong, so we should all do this. That can be presented in narrative in a way that helps me as an ethicist kind of understand the complexities of it. And I think that's useful, because all too often it's, we're going to try to, this is wrong, this action by a scientist was wrong, this was right, this is the right thing to do. It's way too complicated to boil that down, and yet sometimes in good narrative, like in those books or in others, like Flowers for Algernon, we can see the complexity of the story and think about, yeah, what if that happened? To some degree, they're reflective on the past, and many narratives do, make us refocus on things that have occurred. But they're also good ways to essentially do thought experiments about, well, what would happen if, and is that a world that we want to live in? Is it like, what would that be okay?
Yeah, that's fantastic. Thank you. And I think that paves the way for my final question before we end things. But what do you hope that career clinicians or future psychiatrists carry with them into their professional lives?
Oh goodness. um,
Beautiful loaded question.
yeah, it's I think it's hard. Because early career, it's challenging, because a lot of it is just figuring out the fundamentals of things like diagnosis, right? And what treatments are appropriate, and um, what to do in a challenging situation, and so I think early career physicians have a lot to take on and to understand, It's only been now, I don't know, I graduated medical school, it's 30 years ago now. And so it's kind of in my 30th year post medical school that I'm just now starting to feel like I've got a kind of the ability to think a bit more broadly. Um, and I see now the real value in the human narrative and in making sure that we maintain that connection. And so it's challenging times are going to be ahead because the early career psychiatrist physician is going to need to understand all of those diagnostic treatment aspects, the fundamentals. They're going to have to navigate a new world of technology and figure out how they're going to incorporate that. And I hope that they don't lose this human aspect as well. So it's, but that's what I would say, and it's about at least making sure that there's still going to be room for the human narrative. Otherwise, I'm not hopeful about the role that physicians will be playing, 10 years from now.
Right. Dr. Weiss, thank you so much for this conversation. It's been profoundly insightful, and I know our listeners, many of whom are students, writers, caregivers, and patients themselves, as well as future clinicians, will take so much from your reflections. And to our audience, thank you for joining us. You can explore more narrative work on the mind, medicine, and meaning at reapparitionjournal.org. We'll link relevant readings and references below. Until next time, thank you for listening.